Jeff has given me permission to be provocative, and I'm the only thing that stands between you and lunch, and that is a very dangerous combination. So I have a provocative title to my talk. I'm going to talk about nursing home abuse, and the title is Violence in the Nursing Home, Who's Doing What to Whom? And I've got some, I'd like to start with some disclosures. The first is that I am, while a community elder abuse researcher, I'm also a community nursing home doctor. This is the first time I've been asked to come to IOM to speak about nursing home abuse. My work has been really in community elder abuse, and I'm appreciative of Jinshi citing some of my early studies. This is really an amalgam of those two careers. I've been the primary care physician to thousands of nursing home residents over my career, and I know the realities of what it's like to practice in a long-term care facility. This is a presentation about institutional elder abuse, not institutional elder neglect. I'm interested in understaffed homes where people get bed sores and they're not changed, but I'm talking now about physical violence, verbal assault, sexual assault, and I want to make that very clear, and I want to state emphatically that we should have a zero tolerance for staff abuse of nursing home residents, period. I want to be unequivocal about that, but I also believe that the field of institutional elder abuse is suffering from what I would call a risk psychology problem, and here are some familiar risk psychology problems. A rash of burglaries prompts a young mother to buy a handgun when data suggests gun ownership is a major risk factor for homicide death during a robbery, right? A woman crippled by arthritis, this comes from my own practice, something I'm dealing with right now, refuses to undergo a total knee replacement because a cousin died of anesthesia complications decades ago, even though she could walk again if her knee were replaced. A man reads about a plane crash and chooses to drive from Los Angeles to New York City, even though the risk of death from a motor vehicle crash exceeds that of air travel. And here's one of my favorite ones. The media barrages the public with reports of frail elders being beaten by nursing home staff, and several things happen. Legislatures decry the epidemic and enact laws intended to wipe out the scourge, often without evidence. Swarms of State Department of Health surveyors are trained to detect abuse in all its forms and cite facilities, and they close some. Criminal background checks are mandated not only on all employees, but residents now of nursing homes, even though the data for that are not terribly compelling. And industries emerge to train staff and facilities to prevent staff abuse, diverting money from actual care, okay, all without evidence. I see people shaking their heads up and down. And meanwhile, major forms of violence in long-term care that pose the greatest threat and the greatest risk to residents go unaddressed. And with that, I'd like to talk a little bit about the chronology and the intensity of public and even academic interest in nursing home violence. And Pam, I'm going to give an ecologic model of this and show you some data as well. In the beginning, and still, there was interest in staff abuse of residents. In the 70s, in my state, New York State, there were odious descriptions of abuse at the hands of staff, and it led to OBRA and legislation, which I fully approve, meant to protect nursing home residents. Then, about 15 or 20 years ago, there was a sort of a frail or feeble literature on residents' abuse of staff. We asked CNAs if they had been physically assaulted, usually in the course of morning care, by their residents, and we got anecdotal reports of that. Fully 50%, I think, of staff described being physically assaulted in the course of providing daily care. More recently, and this has been my work that I'll report a little bit about today, is resident-to-resident aggression. This field is 5 to 10 years old. I'll talk a little bit about the R01 I have from NIA to look at this. And then there's a sort of an interesting organizational psychology and behavior literature in the workforce about staff-to-staff aggression. Now, how naive to think that this doesn't impact a culture of violence within long-term care. So how does this comport with actual versus potential harm to the greatest number of victims? I've used surveyor language here. I know this is an international forum, but many countries use similar language. We talk often about actual versus potential harm to a few versus lots of residents. People familiar with that language in the survey process? Well, I would argue in this scheme that the risk to the largest number of residents from staff abuse is actually low in the year 2013, right? I mean, I've spent tens of thousands of hours in nursing homes effectively, as a physician, I have never physically seen a staff member, as an elder abuse expert, beat a resident. However, every day that I go into a nursing home, every day I see residents hurling racial epithets at one another. I've seen residents physically strike one another, do wheelchair roller derby and try to run each other over effectively. Rather unstudied. I would argue that resident to staff abuse, and I'm going to show you the best data, a paper that just came out, I think, that looks at this, is really of medium sort of risk to residents. Why? Because how naive to think that if you're untrained or poorly trained and a resident strikes you, you might not sort of retaliate at some point. And again, also, I believe that staff-to-staff aggression, verbal conflagration, workplace violence, tension, effectively influences this process. So let me talk a little bit about resident-to-resident elder mistreatment. And here's the definition I've used in my work most recently. We've defined it as negative and aggressive physical, sexual, or verbal interactions between long-term care residents that would likely be construed as unwelcome by the recipient in a community setting, and that would have high potential to cause physical or psychological distress. Now, I don't know about any of you, but if one of my junior faculty came into my office tomorrow morning and sort of struck me, didn't have to strike me, but said, hey, Lachs, pick your favorite dirty word, I think I'd probably have to lie down for a couple of hours, actually, to get over that. And yet, in these environments, this sort of thing goes on all the time, and we have acculturated between all those simplistic dyads that I've shown to you, and the dyadic model is simplistic. I'll talk a little bit about that. Nonetheless, studying violence in the nursing home creates some really, really difficult problems in terms of prevalence estimation. Kathy spoke at the beginning about this. The field of domestic violence relies heavily on self-report to case find and ascertain prevalence. If this were a flu epidemic, we would do nasal swabs. If this were a cancer registry, we would look at autopsies and have very good data from tissue samples to know what the prevalence of head and neck cancer is in a certain jurisdiction. In domestic violence, we ask people, right? We have no pap smear, we have no colonoscopy, we ask people. That's the gold standard. That's how we ascertain prevalence. This is a real problem in nursing home populations. The events are ephemeral. They occur 24/7, 365. Rates of cognitive impairment are astronomical. Kathy decried the problem with this in the community. How do you get to a nursing home? Cognitive impairment, all right? Dementia produces false positives and false negatives. And the use of proxy respondents is incredibly problematic in this situation. So one of my least favorite papers in nursing home elder abuse prevalence, maybe some of the co-authors are here, I apologize, is they asked a bunch of family members, has your family member been abused in a nursing home? And that served as the basis for a prevalence rate, okay? Let me just tell you, I work in nursing homes, okay? And even in the greatest facilities, there were very few truly happy customers, okay? And that's not a way we should be deriving prevalence in my estimation. So I'll talk a little bit more about how we've been going at this. I'll talk a little bit about what we call RREM, resident-to-resident elder mistreatment. And I'm going to show you some hot off the presses data on resident-to-staff aggression to show you how we might get at risk factors. This is a large NIA-funded study of resident-to-resident elder mistreatment in 10 facilities. The aims have been to estimate the prevalence of resident-to-resident elder mistreatment and to identify resident, facility, and contextual characteristics in an attempt to look at how and why these occur, to develop intervention strategies. And because case finding is difficult, we use a triangulated mechanism to case find, several different sources. We have an RREM instrument, which is translated thanks to a colleague, Mildred Ramirez, in Spanish and English. It's culturally validated. That paper just came out. And we administer this to residents who have capacity. We have a capacity screen, and we say, has this happened to you in the last 2 weeks? That's a look back. Has anyone hit you, struck you, thrown food at you? Have you been cursed at, sexually assaulted, other kinds of advances? And for those without capacity, we ask primary CNAs. We also look at incident reports. We actually borrowed some methodology from nurses at the University of Pennsylvania using something called shift coupons. This was created in the 80s during the HIV epidemic and occupational needle stick injuries, where events that occur very ephemerally aren't recorded. We have a little coupon book in which you observe something, you can drop it and put it at the nursing station. It's been a very interesting adopted methodology. Extensive measurements of covariates, so we know all about these people, not only the MDS, but research level instruments. I'll show you a few of those and some aggregate data in a minute. There's a wonderful NIJ-funded sub-study, a forensic chart review to determine if substantiated RREM is documented. So often people will see a roommate change or an undocumented fracture. What's that about? Could that be resident-to-resident aggression? And staff, and this is the data I'm going to show you now, have also been asked if obstreperous behaviors were directed at them from residents in the prior 2 weeks. And again, this work was just published. So here's some data. If you can't drill down, I'll read you the highlights. But this is 282 CNAs reporting on the behavior of 1,552 residents over the previous 2 weeks, and whether they directed verbal, physical, or sexually aggressive behavior towards them in a prior 2 week period. In terms of verbally aggressive behaviors, 9% in the prior 2 weeks. 2 weeks, a 2 week look back. This is not an annual incident rate, okay? Screaming, using bad words, bossing around. Physically aggressive behaviors. In the past 2 weeks, 3.9% reported hitting, 2.6% kicking, you see as we go down, a small number of sexual events, and so a total of 15.6 residents over the course of a 2 week period, or 15.6% or 242, reported this in a very, very short period. Here's where it occurred, corroborating the sort of morning setup story that it was in the patient room, but sometimes in the dining area, common activity area. And here's the time of day in the morning. About 85% of episodes occur in the morning, typically in the qualitative part of this study during morning setup, when we have to get people dressed, bathed. Again, I'm trying to show you this kind of data can be collected if we effectively use methodology. Here's a sophisticated multivariable analysis. The bolded items are the ones that show risk factors or protective effects. In terms of demographics, being Hispanic or being African American was actually borderline protective of being a resident participating in resident-to-staff aggression. That's interesting. I'll talk about that more in a second. But look at these other characteristics, some of which are potentially modifiable. The disordered behavior index. So there are certain kinds of behaviors that are associated with resident-to-resident aggression. Affective disturbance, the mood symptom scale, I don't know if you know that instrument, but effectively, depression in the resident may be associated with aggressive behavior. Some of my geriatric psychiatry colleagues would say a highly treatable entity within the facility. And it's not only being ADL impaired, but it's the intensity of ADL assistance you require. So, being ADL impaired with transfers requires, a minute or two to transfer, but needing lots and lots of intensive ADL assistance seems to be a risk factor for this. And again, I can give you the citation. This came out in the Journal of General Internal Medicine just a week or two ago. The conclusions of this study were that resident-to-staff aggression is an extremely common phenomenon, with over 15% of residents exhibiting resident-to-staff aggression in only a 2 week look-back period. Prospectively, largely collected data. The resident-to-staff aggression was verbal, physical, and sexual. Residents demonstrating the behavior were more likely to be white, require more ADL assistance, and have affective and behavioral disturbance. The protective role of ethnicity in resident-to-staff aggression may be a true factor, a biologic factor, or it may be related to reporting biases. It could be that the people providing service in nursing homes, we know that in the United States, largely to be a people of color, diversity. It might be that, in fact, that could be the basis for a lower rate. It could be that that racially discordant dyads might be more likely to report, so that's a possibility. Insofar as resident-to-staff aggression is prevalent and likely to influence quality, it requires further study. I'd like to make some general comments about the epidemiology of nursing home violence in closing. I think this can be studied if innovative methods are employed. I think it's a drastically needed agenda of research. I think that our initial focus on staff abuse was appropriate, but now is probably overemphasized. Again, this surveyor language of actual versus potential harm. I think that the dyadic model of violence I presented is useful for epidemiologic studies, but incredibly simplistic. And I go back to the comments earlier that Pam made. Jeff and I had a conversation about this ecologic model of violence. I mean, you work in these facilities. Violence acculturation is insidious. A culture of violence, I believe, is contagious. And I think we should be looking at youth models about the school, the family, the environment. I mean, a very famous paper from the 80s when the world of the nurse's aide enters the world of the nursing home, in which individuals with their own backgrounds of domestic violence come into facilities to care for the frailest in our society. That has to have an impact, okay? I think these ecologic models of violence are increasingly recognized as valid and highly, I think, suitable for developing interventions. I'm not in any way minimizing the complexity of that. And I think we need to turn our scientific attention to nursing home violence in all its manifestations to protect staff and residents and promote the highest quality of life. I have to give a brief shout out to folks in the room who've been instrumental in this work. At NIH, my friend and colleague Sid Stahl, the poster child for unsuccessful retirement, as I called him earlier today. My new program officer, Melissa Gerald at DOJ, Carrie Mulford, Andy Mao. At the New York State Department of Health, Beth Dichter, the folks at the Hebrew Home for the Aged who are here today, and both in the research and administrative capacities, have been amazing. It used to be that nursing homes ran from the topic of elder abuse. I mean, we really need to study this in facilities. We really need the help of these facilities to do that. And Jan Reingold and Joyce Solomon have been just amazing at really leading the charge here. My scientific collaborators at the Hebrew Home have been Jean Teresi, Mildred Ramirez, and Stephanie Silver, and Kim Van Heidsma in Philadelphia, Carl Pilmer in Ithaca, and one of my mentees at Cornell, Tony Rosen, has been a very important collaborator. So I think I'm slightly under time. I'm appreciative that you would listen. Thank you very much.